Dr. Elena Stoffel is an associate professor of gastroenterology. She is the director of the Medical Genetics Clinic at Michigan Medicine, and she is the assistant director of cancer disparities within the community outreach and engagement component of the Rogel Cancer Center. Dr. Stephen Katz is a professor of medicine and public health. He is the director of the Cancer Surveillance and Outcomes Research Team. And both of our presenters today hold U01 grants from the NCI, which were funded under the Biden Moonshot initiative, both focused around genetic testing, but in different populations and with different focus areas. And so we're really excited to hear from both of them today. And I'm keeping this short so that we have time for both of them. I will monitor the chat, so please go ahead and type questions into it. We're going to start with Dr. Stoffel, and Elena, if you want to share your slides, you can go ahead and do that. And then we'll maybe take a question or two, and then we'll move right into Dr. Katz. And then we'll take some questions at the end. And after that, we will have the opportunity to go into breakout rooms for those who are interested, as we've done for some of the prior seminars. So with that, Elena, please take us away.
Well, thank you so much, Sarah, for your kind introduction. And it's really a pleasure to be here talking to you today about some of the work that our team is involved with to hopefully promote the adoption of precision medicine in oncology in our state. I wanted to start with just a case to kind of set to frame the discussion. This is a 61-year-old gentleman who was diagnosed with pancreatic adenocarcinoma. And the question is, how can genomic testing impact his clinical care? Well, as many of you may be aware, what we know about genetic susceptibility to cancer has continued to evolve over time. And at this time, we find that approximately 5 to 10% of cancer diagnoses can be associated with a genetic susceptibility to cancer. So whereas the majority of cancers still arise as sporadic events, approximately 5 to 10% of cancers can be attributed to a genetic first hit. This diagram that we created for one of our papers basically illustrates how we conceptualize genetic susceptibility to cancer. The pink circles represent genetic susceptibility to breast and ovarian cancer, the blue to colorectal and GI cancers, and the green to pancreatic cancers. And what is notable here is that there's a lot of overlap. So a lot of the DNA repair genes are involved in genetic susceptibility to many different types of cancer with overlapping spectra. And what's really important to recognize is that from a number of epidemiologic studies, we know that highly penetrant genetic alterations associated with cancer risk are much more common than we first thought. Multiple studies have demonstrated that the population prevalence of BRCA 1 and 2 alterations is as high as 1 in every 300 people in the general population. In some populations, such as individuals of Ashkenazi Jewish ancestry, it's as high as 1 in 44. Similarly, Lynch syndrome, so alterations in the DNA mismatch repair genes associated with Lynch syndrome, have a population prevalence of about 1 in 300. So this means that there are a lot of people out there with genetic susceptibility to cancer who don't know that they have this. So here's our gentleman with pancreatic cancer. I was diagnosed with pancreatic cancer. What, if anything, should my family do? In looking at this diagram is basically a family pedigree, which demonstrates his family history. So our patient has 4 children. He has a sister who had breast cancer at age 55. And the argument that I want to make is that for this gentleman, genetic testing may actually be very important. So,
one of the many things
oops. Sorry. Sorry, that was a slide that was recorded. But basically, one of the things that we have recognized that the MyOncoSeq study showed us is that in evaluating patients with genetic susceptibility, in evaluating patients with advanced cancer, seen here at Rogel Cancer Center, up to 1 in every 6 patients were found to have germline alterations associated with cancer susceptibility. And that's across several different cancer types. But when we look at individual cancer types individually, we see that 1 in 10 prevalence of pathogenic germline variants seems to come up again and again, such that in pancreatic cancer patients, approximately 1 in every 10 individuals will have a genetic susceptibility germline alteration. And this led us to publish an ASCO provisional clinical opinion about 3 years ago to recommend germline genetic testing for all patients with pancreatic cancer. Now, what's interesting about this story is that when we put out this provisional clinical opinion, we got a lot of feedback on it from oncologists saying that there is absolutely no point in genetic testing for patients with pancreatic cancer because survival is dismal anyway, and this testing is not going to make any difference for them. And who cares about what information this can provide to the family members, because the oncologist's primary role is to treat the cancer. Well, interestingly, what then happened and what was published earlier or just after our provisional opinion was that data emerged to demonstrate that a germline genetic test demonstrating a BRCA alteration in a patient with pancreatic cancer actually does have tremendous impact on their own medical management. And here, in this New England Journal paper, maintenance treatment with the olaparib was associated with a significant prolongation in survival among individuals with BRCA mutated cancers. So all of a sudden, then the oncologists are actually much more interested in offering germline genetic testing to patients with pancreatic cancer. And fortunately for this gentleman who had a sister with breast cancer, germline genetic testing in him demonstrated that he had a pathogenic germline variant in BRCA2. And so he was actually eligible for PARP inhibitor therapy. And as we'll talk about a little bit later, this has a big implications for management of his family members as well. So who actually gets genetic testing in Michigan? And we know that the indications, sorry, as we know more about conditions for which germline genetic testing is available, we know that the indications for which patients meet criteria for genetic testing continue to expand. At the same time, we also have genetic tests that include more genes and have actually gotten cheaper over time, with current costs coming down from up to $4,000 for just germline genetic testing for BRCA1 and 2 to out-of-pocket costs of $250 for multi-gene panels through many commercial laboratories. So we have more people now who are eligible for germline genetic testing. The cost of germline genetic testing has come down. So what do things look like here in our state of Michigan? Well, we are very fortunate to have the opportunity to work with the Michigan Department of Health and Human Services, who actually, the MDHHS Cancer Genomics branch actually has a grant from the Centers for Disease Control for cancer genomics best practices. And so for over 10 years now, they've actually been tracking who gets genetic testing in Michigan by partnering with genetics clinics throughout the state. So in the map to the right, you can actually see several dots demonstrating where the genetic clinics are in Michigan, as well as shading demonstrating where the patients are actually getting tested. And in this graph with the dark line, we see the number of referrals over time, which has tremendously increased. In the light gray line, you see the number of people who receive genetic testing, but you also see in the bright blue line at the bottom that the number of individuals with pathogenic germline variants has increased, but not at the same rate as the number of people that we're seeing for testing. So this argues that even though we are seeing more people for germline genetic testing, many of those people might not be the best people to be testing, or rather the people most likely to have germline pathogenic variants are not being captured here. So what things look like in the state of Michigan here is that when we look at who gets genetic testing, 86% of people who come in for germline genetic testing are women, and 84% of them are white. When we look at what diagnoses patients have, about a third of patients who come in for testing have no personal history of cancer and are coming in primarily because of a family history. So when we look at what cancers are bringing people in, it is overwhelmingly breast cancer diagnoses. personal or family history of breast cancer. And as you see here, the other cancers for which the prevalence of germline pathogenic variants is at least 1 in 10 are really underrepresented. So what determines whether a patient gets offered genetic testing or whether they complete genetic testing? So here again is the map that basically shows where the cancer genetics providers are in the state of Michigan. And as you see, it kind of matches where we saw that the patients were getting tested in Michigan. And where we came at this was saying that there are a number of different things on the patient, provider, and system levels, which are all in play, which determine whether a patient with a cancer diagnosis will get genetic testing. And so from the provider end, what things have we been able to identify? Well, we know that many providers don't feel comfortable discussing genetic testing or ordering genetic testing, but we also know that being able to identify which patients meet criteria for genetic testing is a tremendous stumbling block. We also know that things are changing, and I discussed with you that there are many new models for delivery of cancer genetic services. We have moved from only having genetic testing available through genetic specialists. There were insurance plans in the past that actually required that you meet with a genetic counselor or with a geneticist to be able to get your genetic testing ordered and paid for by insurance. But we're now moving beyond that, in that there are now more opportunities for non-genetic specialists such as oncologists, surgeons, OBGYNs, primary care providers to order genetic testing. And then most recently, several companies have initiated direct-to-consumer genetic testing for clinically CLIA certified germline genetic tests, which is a really interesting and exciting option. But what determines who gets genetic testing in the state of Michigan? Well, we have a lot of diversity in our state, and I've already told you that the majority of the people who are getting germline genetic testing are white women with a personal or family history of breast cancer. We know that there are a number of patient level factors depending on their demographics, their culture, what they know about genetics, how comfortable they feel advocating with their providers about genetic testing. We also know that if a provider never recommends germline genetic testing, it's really unlikely that a patient will follow through. And certainly there are tremendous system constraints, including how do I get genetic testing and how do I get genetic testing paid for? And so on the basis of this, this is what led us to our proposal, which is our U01 funded MIGHT study. And this is a study that I have the pleasure of working with Jennifer Griggs and Ken Resnikow as my multi-PIs, which we have partnered with two really important groups. One is the Michigan Oncology Quality Consortium, which is a group of 68 oncology practices throughout the state of Michigan, directed by Dr. Griggs. And then our second partner is the Michigan Department of Health and Human Services and the Cancer Genomics Branch. So the objective of this project is to expand genetic screening and testing for cancer patients in the state of Michigan. We approach this with two aims. Our first aim is to evaluate the effect of provider and practice level interventions, primarily looking at the effect that teaching providers about taking a family history will have, and also providing a value-based reimbursement on the outcome of looking at the percentage of subjects who have a complete family history identified by chart audit. The second aim is actually a patient-focused behavioral intervention. But let's start first with the first aim. So I mentioned that in the clinical competencies, one of the things providers are very uncomfortable with is identifying which patients meet criteria for genetic testing. And we know that looking at personal genetics risk assessment is incredibly important. And ASCO has actually provided a best practices quality measure of recording the types of cancer diagnoses and the ages of cancer diagnoses in all first and second degree relatives of a patient with a newly diagnosed cancer. So what we know here from data that Dr. Griggs's MOXIE consortium has put together is that for oncology patients in the state of Michigan, fewer than 20% of patients have a complete family history recorded in the chart. So a big gap is that when you're seeing a patient with a cancer diagnosis, our providers aren't thinking beyond that cancer. They're not looking at the family history. So how can we help them look at the family history? Well, one of the things we had developed a few years ago with the Rogel Cancer Center's Cancer Center Health Information Group was to develop a tool that would collect family history from patients. So this is a tool that is web-based. It asks patients questions. It is modeled on the way a genetic counselor elicits a family history and collects enough information to create a family pedigree. And it actually runs the PREM a risk model for identifying patients at high risk for Lynch syndrome. So with this information, we're able to deploy this family history tool in 68 oncology practices and actually help providers have the information about a patient's family history at their fingertips. So the second part of this provider level intervention is actually an education campaign in conjunction with the Michigan Department of Health and Human Services Cancer Genomics branch. MDHHS has put together a hereditary cancer toolkit to provide patients, or to provide both patients and providers with indications for germline genetic testing, a hotline for calling if you have questions about where to get genetic testing or how to order genetic testing, as well as a number of other resources about other groups, other practices in the state of Michigan that have cancer genetic services. So for AIM-1, this provider and practice level intervention, we're actually rolling out the family health history tool in a stepped wedge design among the 68 oncology practices over 4 years. And then at year 4, Moxie, in conjunction with the with Blue Cross Blue Shield of Michigan, is going to offer a value-based reimbursement for high performing practices. So we're very excited to roll this out in the 68 oncology practices in Michigan. Of course, COVID has been a little bit of a barrier to us in that many oncology practices have been overwhelmed, but we're really excited to roll this out with practices, and certainly even though we're getting started a little bit later, we're going to be on track to get these practices up and going. So that leads us to the second aim. So the second aim, so we figure once we teach providers how to identify patients at risk for hereditary cancer syndromes, how do we actually work on patients to get them interested in germline genetic testing? So we are proposing a randomized controlled trial with 3 arms of patient level intervention. The first arm is usual care. The second arm is randomization to tailored messaging using a mobile optimized website, which we fondly call the virtual genetics navigator. And then the third group is 2 telephone sessions with a genetics health educator trained in motivational interviewing. And this is where Ken Resnickow's expertise is absolutely invaluable. So the primary outcome for this is the percentage of subjects who complete germline genetic testing, which will be assessed by self-report. So this diagram basically shows us how we get from AIM-1 to AIM-2. As I mentioned previously, rolling out the family health history tool in 68 oncology practices throughout Michigan is going to give us approximately 42,000 newly diagnosed cancer patients over the study period. Of those patients, maybe 40% of them will complete the tool, and maybe 10% of those who complete the tool will meet criteria for germline genetic testing. Among individuals who meet criteria for germline genetic testing, we will elicit permission to recontact those individuals and offer them enrollment in the randomized trial, at which point they will be randomized to receive either usual care, the virtual genetics navigator, or the 2 phone calls with the genetic counselor. So what do these interventions offer? Well, that's a great question. And that's where Ken Resnickow's group's expertise comes in, because we have done a lot of work in terms of our clinical experience working with patients and seeing patients in the cancer genetics clinic, as well as Ken's group in promoting behavioral change, really led us to develop the content, which includes, looking at questions of, why is genetic testing important? What are the myths and facts? What are attitudes, norms, motivation that are specific to each individual? And then moving patients from why should I get tested to how should I get tested, by providing information that takes into account what their potential barriers are to testing and how we can overcome those barriers. And certainly being able to provide this in a slick tool that will do what our genetic counselors do in talking to patients, but be able to do this electronically in a way that patients will get the information that they need, but that won't use up provider time to get all of this information across. And so hopefully this will actually play, but this is just a brief movie demonstrating what the virtual genetics navigator looks like so far. There are many different places where patients are able to click to be able to get more information about what they're more concerned about and what questions they have. And so by navigating through the tool, we're able to capture what patients are interested in the most, and we're able to, based on their individual answers to baseline surveys, to be able to provide them with the content that is most relevant to the questions that they have up front. And then finally, in a wrap-up section, we have information on how patients can get germline genetic testing and where they can go to get additional information. And the Michigan Department of Health and Human Services Cancer Genomics Hotline is going to be absolutely invaluable, because we'll also be tracking information that are questions that patients and providers have when they contact MDHHS. So in terms of data collection and expected outcomes, I mentioned to you that we're going to be looking at the number we're going to be looking at the rollout of family history collection in the various oncology practices, and the practices are going to be assessed through chart audits by the Michigan Oncology Quality Consortium Group. For AIM2, we're looking at the uptake of germline genetic testing at 6 months, assessed through patient surveys and self-report. We're also going to be collecting data with the virtual genetics navigator as well as the motivational interviewing phone conversations. The expected outcomes, well, we expect that uptake of genetic testing is going to increase overall, because we think that as providers get more comfortable and learn more about the value of germline genetic testing for their patients and families, this will increase. But we also expect that in the patient level intervention arms, we're going to see a much more dramatic increase, because in talking with patients, there are a lot of knowledge gaps, and there's a lot of barriers that we can actually work through with the majority of patients. And then in terms of secondary outcomes, we're really interested in kind of assessing how can we move provider knowledge with regard to genetics. We're also interested in looking at the mediators of uptake of germline genetic testing, because in particular, we know that in Michigan, uptake of germline genetic testing among Black individuals and individuals of MENA ancestry are really, really low. And we want to see what messages may be most effective in overcoming the barriers to testing in those specific populations. And then finally, we also want to examine the utilization of the different models of genetics care delivery. You know, how many people are actually going to choose to come to genetic specialty clinics versus how many people are going to feel comfortable ordering genetic testing online for themselves through a reputable laboratory. So I think we're going to have a lot of exciting information at the end. So going back to our gentleman with the BRCA2 alteration, this was very important information for him to get, but it's even probably just as important, if not more important, that this information is now available to his family members, including his children, siblings, nieces, and nephews. And that is where Ken's talk is going to take off. So just a word to thank all of our collaborators on this project. And thank you very much.
Thank you. Excuse me. Thank you, Elena. That was awesome. So much cool stuff happening in your project. I'm hoping that I think we're going to move right to Dr. Katz. I don't see any questions in the chat, but at the end of your talk, Stephen, I'd like maybe Elena, you to say a little bit about working with the Quality Collaborative and kind of how that has rolled out if we have time, because I know there's a lot of interest there. So with that, and other areas of your talk I have questions about, but Why don't we go ahead and get started with Stephen, and we'll have a little bit of time, hopefully at the end, for a few questions. Folks, just please type them in the chat and we'll bring them up at the end. Stephen, please.
Thank you. Sarah, you can hear me and see me?
Yes, perfect.
Thank you so much. Yeah, Elena and I had a chance to share the podium maybe about a year and a half ago, pre-pandemic, and we had so much fun talking about this. It was so moving at the Rogo Cancer Center. Big group showed up. We went back and forth and had a lot of input from medical oncologists, surgical oncologists. A lot of clinicians were at our talk, and now I'm sitting in front of a screen in my Texas lounger, and Elena, you're wherever you are in your office, and I'm looking at little people and how the world has changed. But this is a very effective way to communicate, and as a communication scientist, and it's a pleasure to be with all of you today. I'm going to spend a few minutes talking about the family conundrum, the issue of genetic risk evaluation, and how it moves from the individual patient to the family. And Elena touched on that in her excellent first talk. And it's a big focus of our research, and I'm going to share that with you. So I'm also going to share a case. Let's see my slides. Yes, here we go. Of Miss Landry. She's a 53-year-old grade school principal who is diagnosed with triple-negative breast cancer. She undergoes germline genetic testing, which reveals a BRCA1 mutation. She undergoes treatment. She gets bilateral mastectomy with reconstruction. And we know from our research that virtually all women with BRCA after breast cancer diagnosis undergoes bilateral mastectomy, that both addresses and decreases the risk of recurrence in the treatment the effectiveness of treatment for the cancer she has, and also reduces markedly the probability of a new cancer that she could get. She undergoes systemic therapy to address the recurrence of the cancer she has, and she's advised to consider salpingo-oophorectomy to reduce the future risk of ovarian cancer. So why this particular suite of recommendations around therapy? Well, if you look at BRCA1 carriers, and let's take them after diagnosis, they have a quite high probability of having a primary breast cancer in the future. And that bilateral mastectomy can virtually zero that risk out. But some women with BRCA carriers might consider many do, breast MRI screening, which is not as effective as bilateral mastectomy, but an alternative. But a very big deal for BRCA1 patients, women, is the risk of ovarian cancer, which goes from a rare possibility of a rather fatal disease to a relatively common or relatively frequent occurrence in the future. So that salpingo-oophorectomy in this patient can reduce this risk over time of ovarian cancer from very substantial to nearly zero. We have written, our research team, with Lauren Wallner's on this call, Jennifer Griggs, Sarah Hawley, and others, we have written well over 100 papers around the issue of decision-making, communication, and patterns and quality of care of breast cancer since about 2004. The rise of germline genetic testing in this engagement is a real important issue, and probably the most challenging issue in oncology today. We wrote 5 years ago on this topic of mainstreaming mutations, the growth of genetic testing after diagnosis. And I looked at this just a couple of days ago, and it's actually more prescient today than it was 5 years ago, which is a little uncommon for a commentary. Test results of germline genetic testing inform relative risk of future cancer versus the absolute benefit of the different treatment options that are discussed with patients after diagnosis. Patients must juggle two different schemas: prevention of new cancers versus the treatment for the one they have. And this is virtually intuitively and cognitively impossible to disaggregate. Clinical utility of germline testing is evolving. Even today, 5 years later, 6 years later, there's wide variability in cancer risk estimates for individual patients with pathogenic variants, and the growing problem of addressing variant of unknown significance. Thus, test results have implications for the relatives, and that is unique, virtually unique, that a test result in an individual would have an effect on others outside of an infectious disease. There's probably not another example in non-infectious disease than germline genetic testing. And thus, it's major challenges of incorporating genetic risk evaluation to treatment decision workflow with Elena punching it in with her research team in terms of focusing on patients and getting the right patients tested with the right test and the right information and the best possible decision making. However, Ms. Landry is in a family tree, and there's a great, enormously growing need to improve communication and outcomes in families at high risk of hereditary cancer syndromes. As more and more patients are tested, thus comes the real issue of what do family members do with the information that Ms. Landry does or does not share with the members. Ms. Landry sits in a pedigree, and Elena talked about this briefly with her presentation. Ms. Landry sits in a pedigree where first-degree relatives, father, mother, daughter, son, brother, sister, have a 50% chance of BRCA mutation. 25% chance of a BRCA mutation in second-degree relatives, aunts and uncles, nieces and nephews. So this dynamic that triggers after a germline genetic test reveals a pathogenic variant is essentially unstudied, and essentially we know very little about how and in what way we should improve these outcomes. I wrote a commentary with Alison Curion at Stanford on the emerging opportunity and challenges of cascade genetic testing for population-wide cancer prevention and control. Patients are generally charged with communicating with relatives about health risks under HIPAA regulations. Providers are generally not allowed to reach out to individuals, whether it's a relative or a friend, to share personal health information. It must run through the patient. Patients and clinicians are necessarily focused on implementing the cancer management plan for the cancer that they have. Counseling services are increasingly stretched, as Elena reflected on, stressed as more patients undergo more complex testing. Engaging relatives is particularly challenging because they live frequently in distant locations and receive care in disparate practices. Think about your own first and second degree relatives in the context of sharing something like the results of your cancer diagnosis and your germline testing. Patients' insurance does not cover support services for relatives, and thus there is an emerging major challenge for oncologists, primary care doctors, genetic counselors across cancer conditions dealing with this. And it shouldn't be surprising that cascade genetic testing is relatively uncommon even in families at high risk for a hereditary cancer syndrome. Now, what does a relative do with this information that they get from a family member? Well, they invariably will go to the internet. They could actually get some testing. They could get testing from 23andMe, which is non-medical grade genetic testing with regard to breast cancer, but is probably the most common test. Actually, now that I think about this, Elena, it may be the most common genetic test for breast cancer in the United States because of how diffuse it is in the population. They can also get medical grade testing, quality medical grade testing from a company called Color in California, who we work with in our research, or Invitae. And increasingly, these companies are making available medical grade quality genetic testing to people. They could go to a primary care doctor, and I'm not sure this one would be particularly helpful, maybe. And that primary care doctor would be charged with helping that relative think about, likely refer to a Elena Stoffel, to be clear. So we have a study that's unique, probably in the world. Yeah, it is unique in the world, to evaluate to what extent we reach relatives, to what extent we communicate effectively with relatives, to what extent relatives do the right thing the right way. And also the study looks to improve and facilitate genetic risk evaluation. So this is the Georgia-California Genetic Information and Facilitated Testing, the GIFT study. It is part of the funding of the Beau Biden Cancer Moonshot that Elena referred to, and also funded by additional funds from the American Cancer Society. I lead it with Alison Curion, who's the head of medical genetics and a medical oncologist at the Stanford, and Larry Ahn, who's the director of CHCR here at Michigan, along with an incredible group of folks, which I will be thanking at the end of this discussion. Rachel Toko, who's on this call, is our research director. So the GIFT study aims are to improve the delivery of Cascade genetic risk evaluation in families with hereditary cancer syndromes. Our aims are to develop and test a virtual, family-centered communication and decision-making platform we call the Family Genetic Health Program, and to deliver that to patients and relatives, and I'll talk about in a moment the sample, to determine the independent effects as a clinical trial of two major features of this intervention. The level of personalized family genetic risk support, that is an automated tailored platform, plus or minus a human to help families and patients navigate these decisions. We call that the FGHP Navigator. So randomized to everyone gets the platform with or without a human navigator, and the cost of genetic testing for relatives, and note the pricing, free versus $50. Elena suggested clinical testing in clinic settings. The charge to the patient, one thing, Elena, you may want to mention that when we have our discussion, the charge to the provider could be as high as $2,000. However, I will say that in medical grade testing is available to people in the United States as an internet or a home-based test for between $50 and $249. The outcomes of our trial are cancer patients' appraisal of communication and engagement with relatives around genetic risk evaluation, relatives' appraisal of decision-making and receipt of genetic testing, and relatives' completion of formal genetic risk evaluation in their whatever practice they're in the country of Canada, the US, or Mexico. The primary outcome is receipt of genetic testing. We are offering home genetic testing to all of the patient relatives clusters in the study, varying whether there is someone to help them think about that versus just the tool, and the price of the testing, free versus $50. Here is the design of the study. Patients are selected from the SEER cancer registry, and I'm going to come back to that in a moment. Adults diagnosed with cancer in 2018 and 19 in the great state of Georgia and California, and tested positive for pathogenic variant. So we're starting with the patient population diagnosed with cancer, and we know that they've had tests positive for pathogenic variant. And I'll explain to you in a moment how we would possibly be able to do something like that. We're going to draw a sample and we're going to survey them. Interested patients, eligible patients will be enrolled, and they'll be randomized to genetic test costs, free or low, automated tailored platform, navigator assisted, no navigator assisted. So there are 4 cells, 4 arms in the study. Navigation with free testing, automated tailoring, $50 testing, and the 2 arms in between. The outcome of most interest is whether, if you build it, do relatives get tested or not. Among many other patient and relative-centered outcomes, the primary outcome is testing. More testing, yes, no. Formal genetic risk evaluation is another important outcome through a survey, and patients and family members' 6-month outcomes include a report of their service provision after this and evaluative outcomes with regard to their experiences with the intervention. So why do we get to do this? Why are we doing this in California and Georgia rather than Michigan? Is because we've developed a unique initiative, I think, in the industrialized world to be able to identify these patients and reach out to them for observational research, but also for interventions. And this is the Georgia-California SEER Genetic Test Linkage Initiative. It is under the oversight and funding of the National Cancer Institute, led by myself and Alison Curian at Stanford, and our registry leadership, cancer registry leadership in the great state of Georgia, Kevin Ward, and the great state of California, Liwa Liu, and Hamilton, under the auspices of NCI, Len Pinberthy, Valentina Petkov, and the brilliant data handling of doing all this, IMS, Information Management Services, in Bethesda, Maryland. Well, we were able to create an initiative that is a partnership between all the 4 test laboratories that perform testing in Georgia and California, Ambry, Myriad, GeneDx, and Invitae. They were willing to partner with us to give us the genetic test information for essentially all of their clients in the United States over the last 10 years. That information is moved to IMS, Information Management Services, and they link that test information, the germline test information, to the clinical data repository of the Georgia and SEER cancer registries, 2013 through 19 diagnosis. This represents a sample of 1,700,008 patients, and it's a uniform data record, patient demographics, tumor characteristics, treatment, survival, and genetic testing, germline, down to the gene and whether that test was positive, negative for the variant, or uncertain, what's called the variant of unknown certainty. I've had an opportunity to share this, this initiative in the United States and also in Europe, and there is no other initiative like it. In Europe, this would not be possible because of both feasibility and also legal privacy issues. The United States uniquely positioned to, number 1, have the registry buy-in, number 2, have the NCI buy-in, number 3, have the lab buy-in, and probably most important, the Departments of Health of Georgia and California have approved this study, which, by the way, waives patient-informed consent and waives authorization, which means if there's a leak in privacy, the PIs are held responsible, not the companies. Okay, well, that is in fact the infrastructure that we have now built to create the GIFT study. So very briefly, from that infrastructure, we will sample 4,000 patients with pathogenic variants and 200 patients without pathogenic variants, actually non-testers, so that the field teams in Georgia and California, when they do the survey, are cloaked and blinded to whether the patient was tested or not. The field teams in Georgia and California, USC and Emory University, are going to perform a survey of these 5,000 patients, 4,400 patients, and get information about them in terms of their experiences, and determine their eligibility, which is that patients have to report that they have a pathogenic variant 3 years later, and that they have at least one first and second degree relative who has not been tested or they don't know. So very liberal enrollment and definition, eligibility definition. Interested patients will enroll at the Michigan site. We expect and hope to get 900 patients of this initial cohort of 2,268 enrolled in the study. And they will be randomized, their family cluster will be randomized to the 4 arms. Test Tech free, Tech only $50, Tech plus Navigator free, Tech plus Navigator $50. Patients will and relatives will enroll in the study and perform baseline surveys after participation. Stanford University is the clinical navigator for the study. Relatives will be invited by the patients, and we expect to get 3,600 relatives invited into the study. Interested relatives will enroll and participate in the intervention, and they will complete a baseline survey. Interested relatives follow the link anytime during the platform experience to receive genetic testing through Color Genetics, which is a internet home medical grade based company in California. Follow-up surveys of these patients, of these relatives, excuse me. So key features of the GIFT study include SEER cancer registry-based selection of patients with high risk of hereditary cancer in the family. So this is essentially a population-based study. Pragmatic approach to engagement of families, inclusive, diverse, low barriers for enrollment. All families receive services including the offer to relatives for low-cost genetic testing, randomized key features that inform next steps, home medical-grade genetic testing through a company. Intervention strategy and platforms are scalable. Maximizing the impact of these results of this trial is that we expect to be able to scale that across the SEER program. We expect that the successful trial outcome could produce a tool that could be integrated into clinical practice, especially low resource practices. And we're partnering with patient advocacy groups, state health departments, clinical societies, and foundations to disseminate the results of this trial broadly. I think I'll conclude, yes, please. And I want to thank, as Elena did, collaboration. These large, whether it's a team science studies that Elena and I just described, don't go anywhere without the intellectual capital, the resources, and the access and availability that comes through a number of different individuals in their organizations. Thank you.
Thank you. Excuse me. Thanks, Stephen and Elena. I just typed a reminder in the chat. I expect folks must have some questions for you. I was wondering though, sorry about the barking. I would love, Elena, you to talk a little bit about the Oncology Quality Consortium, but I was also thinking maybe we could start by asking each of you to say a little bit about the policy implications of the work that you're doing. Stephen, you touched on this a little bit in terms of practice integration and dissemination, but just in terms of like the costs of testing and what the findings of both of your studies may reveal, what might kind of circle back in terms of policy and insurance and coverage, both in the state and nationally. And Elena, maybe you could start.
Yep. So we've come a long way in genetics, in cancer genetics in particular. I think that we have moved from the point where genetics providers were being the gatekeepers for genetic services to now we are at the point where genetics providers are the bridge to bringing genetic services to the larger population who needs cancer genetic services. And I think that through dialogue with insurance companies and demonstrating to insurance companies that preventing a cancer is often cheaper than treating a cancer, we have made a tremendous headway. And I think that it's groups like the Michigan Oncology Quality Consortium, MOXIE, led by Jennifer Griggs, that have built the partnerships between oncology practices and insurers to be able to say, we all want the same thing. We want our population to be healthy. How do we actually work together? And I think that work such as this is going to be really important because, you know, just an hour ago, I had a conversation with a patient who said, you know, my son doesn't want to get genetic testing because he's worried that it will affect his insurability, his health insurance, his life insurance, his long-term care and disability insurance. And I think that through demonstrating that, you know, there are so many, the prevalence of pathogenic germline variants associated with increased risk for cancer is so high that everybody's going to have something. And if we can actually get to the point where we say this information is power and we can actually use this to take better care of people, and that's where we need to be. That's precision medicine.
Thank you. Yeah.
I love
Stephen,
that.
anything to add? I mean, that was.
Yeah, sure. Yeah, it's the promise of precision medicine versus the reality and the practice. I think the biggest bang for both of these studies will be clinical policy rather than health policy per se. I think two, one, clinical policy. Clinicians are, this is one of the most chaotic areas, and Jennifer, you're on this call, so you know, this is one of the most chaotic areas in oncology today. I mean, you know, we have published that surgeons can order this test, medical oncologists, I mean, who talks to the patients about it, let alone how the relatives are engaged in Anchorage, Alaska and Ciudad de Mexico. This is something that, so from a clinical perspective, clinicians will be very interested in the results of these studies because they want to see the bang for the buck and they want to see a better practice context. But the other, and Lynette Hammond-Garrido's on this call, and Lynette and I have had a couple conversations. She's a postdoc in the School of Public Health, about the family dynamic. I mean, what's going on with families and the chaos going on in families around. We've already started this, Elena. We've got a pilot study going to sort of work on our the platform, and we're already getting calls from family members, from patients saying, let me tell you about what's going on with my family. Let me tell you what's going on with my family. There's a hunger for understanding the family dynamics around Germany. So number one, what's going on in practice? That's the practice when the patient hits the clinic. And also then the family dynamics. I think less health policy than clinical policy and family policy, really.
I saw Dr. Griggs unmuted and I was hoping she might want to chime in to this conversation. Or was I over?
I just heard my name and thought I should show up. It's nice to see everybody here. Both of your talks were so good. And I couldn't agree more about family and family structures. You know, 27% of people are estranged from their family. So how do we go about reaching potentially affected relatives? It's such a good question.
Thank you, Jennifer. Please, anybody type in other questions, but I'm going to keep going with, maybe both of you. And this gets a little bit to the MOXIE work that you're doing, Elena. So maybe you can talk about that, or maybe Jennifer wants to chime in. But both of you are doing these kind of virtual interventions, trying to, and through that, reaching really hard to reach populations potentially in our state, which we know we have challenges with rural. And I know some of the oncology practices are located even in the Upper Peninsula. And I mean, Stephen, nationally working with SEER, that's a huge undertaking to kind of partner with that, within that collaboration and kind of reach patients across the country. I wonder maybe if both of you could just take a minute and talk about some of the challenges or reasons for, well, obviously we know the reasons, but just a little bit more about that and how you think that might help.
You know, Elena, you had talked about with our group a couple times the challenges of engaging the practices. Maybe you could spend just a minute or two talking about the practicalities of that, because you're one of the first really big studies on that network. And you've talked about both barriers related even to issues of insurance coverage from practice to practice, but maybe some practice barriers that you're dealing with.
Yep, absolutely. And I'm going to invite Jennifer to unmute herself too, because she has vast amounts of experience working with the 68 oncology practices in MOXIE. But basically every practice is kind of its N of one. You have to say what is important to the practice and what does the practice want to get out of this collaboration. Uniformly, all the practices want to deliver good care to their patients. That's why they're members of MOXIE. But the reality is that each practice has its own way of doing things, and each practice is facing constraints which have gotten worse during COVID. So when you go to a practice and you say, hey, we have this family history form that we want you to start sending to all of your newly diagnosed cancer patients. That sounds easy in principle, but in reality, you actually, and Shana Weiner, who is the Jennifer's liaison to the practices for this project, basically goes and meets with practice managers and talks about how are we going to help educate everyone from the front desk people to the physicians about why this is important and why it's worth the extra bit of time to make sure that patients get this family history form and that the providers review it. So I think that in a nutshell is, working individually with each group to determine what will work for them and how will this fit into their workflow.
And in our case, we're inviting patients to participate through a packet that goes home to them in Macon, Georgia, Sacramento, California. And they don't know what we know. They don't know that we know we introduce ourselves. And our group has surveyed 15,000 with Sarah Hawley and Lauren Wallner. Tim Hofer's on this. we've sent surveys to 15,000 and gotten 10,000 patients returned. This is the first study, Sarah, where we're asking them to do more. And Elizabeth Hershey, who's the director of CHCR, she's on this and on this presentation, and we're just amazed that we're going to be able to do this, and we're going to wonder, if you build it, do they come? When you send the packet home, what is the reaction of patients to join the study? And so I'm really interested in what happens next.
I think that's really interesting because we know from what we see in the clinic that there's a lot of concern about privacy. There's tremendous amount of concern about genetic information and who knows this about me and what am I going to do with this information. We have families where they say, you know, you cannot share my genetic test results with anybody. It's our clinical practice to get a release of information on most patients, so that if we have a family member contact us and say, I'm Jenny Smith's sister, I want to have genetic testing because she had a BRCA mutation, we want to have that release on file so that we can actually share that with the family member. But
Right.
in many cases, you know, patients will say to us, no, you can't share this information with anybody. I deliberately don't want anybody to know this. So I think
we've heard from quite a few clinician groups that what we're doing is rather heretical. I would just end by saying that's why it's a Biden moonshot. That's what Beau Biden moonshot's supposed to be, something that people don't think you can do, and we do it. So that's the exciting thing.
That is a great end of our seminar. We did have a late breaking question come in about incentives to practices. So I don't know, Elena, if you could answer that for your grant, if you are providing that. We will be pulling off into breakout rooms. So that may happen while you're answering, but
so the incentive to practices is brilliant because it's Jennifer Griggs's Moxie's value-based reimbursement. So the incentive to practices is that if they do a good job recording the family history for their patients, they're going to get a value-based reimbursement from Blue Cross Blue Shield in year 4.
So there's a benefit to working with Moxie and some of the other collaboratives and consortiums that we have the opportunity to work with.
We also give the members the opportunity to publish and to serve on an advisory group and to nominate patients to be on an advisory group. And we try to show them the immediate effects of what they're doing differently and reward them in non-monetary ways as well, increasing engagement.
Thanks, Jennifer. Well, Stacy has reminded us all to join the next one, which is actually about CQIs. So this is a great segue. And with that, thank you all for attending.
How do we go into a chat room?
Stay there and you will automatically be put into a room. And please, you know, those of you
I'm in Elena's room because I have questions for her.
It's a lot of fun if you can stick around. Thanks. And Stacy, you can start the